Okay, so we're going to start this exam 3 review session for adult health 3. The content, which should include most all the GI, but some of the neuro, the last few topics of neuro like stroke, TBI, increased ICP, brain tumors, and then all the GI and biliary system, diverticulitis, diverticulosis, hepatitis, liver cirrhosis, end-stage liver disease, liver transplant, and pancreatitis. So uh, let's start with stroke, which is more review from last year, in which that the focus of the content on the plan of care or treatment of patients with stroke or CVA, cerebrovascular accident, and the complications here that are associated with this disease, especially the AFib, atrial fibrillation, and the precautionary um, plan and treatment to prevent thromboses, such as DVTs or acute MI or pulmonary embolism due to the afibrillation or the complication thrombosis result, which may result or from the AFib. So, especially when we put the patient on blood thinners, that's the one of the treatments for the or preventive measures for the AFib or to prevent thrombosis from AFib. So clients with a history of hypertension, clients with AFib, with diabetes, with obesity, um, and hypercoagulation, they all at risk for what is called the embolic stroke, and we differentiated between the thrombotic stroke and embolic stroke. Thrombotic, thrombotic stroke, that's the stroke or CVE that's going to result from the formation of the blood clot within the blood vessels in the brain. However, so either it's hemorrhagic or it's thrombotic. So that's the uh, ischemic stroke, both thrombotic, thrombotic and hemorrhagic, both are called ischemic stroke. However, we have also embolic stroke in which that patient develops the blood clot somewhere else, out of that brain cells and tissues, DVT, PE, acute MI, then the blood clot will travel to the brain and result in a stroke. So that's called embolic stroke. So the prevention of post-stroke complications requires an extensive rehab program to minimize the extent of the residual deficits. So patients with stroke develop complications and deficits, physical and sensory, both, either or both, such as contractures. We have to do a lot of measures to prevent the patient contractures, paralysis, swallowing deficits. So the also, there is one of the complications called heminonymous hemianopsia that affects the visual um, uh, status or visual the vision. So during the acute period of the disease process, then we have to place the objects on the patient's unaffected side. That's one of the practices or best practices and for when we take care of patients with a stroke, especially when they have a hemianopsia. So we're going to place the objects, food, tray, and other stuff, whatever we are bringing to the patient room, to approach patient from the unaffected side, and also to bring these whatever we are bringing to the patient to from the unaffected side. So stroke again, that's a review from Adult Health 2, but make sure that you review all that stuff, especially with the complications associated with stroke. Traumatic brain injury, TBI. So you will read about the etiology, pathophysiology, and one of the techniques or measures or things that we do with the patient is called barbiturate coma. We don't induce, that is induced coma. We induce this type of coma in patients with TBI. And the induction or the when we inject patient with barbiturate medication to induce the barbiturate coma, that's to decrease the formation of the cerebral edema. So the client will be placed on in a barbiturate coma to decrease the cerebral metabolic demands, and that would decrease the risk to develop or the formation of vasogenic edema. This is one type of cerebral edema that can be prevented with this type of medication and put patient on under the coma, which is induced coma here, is to prevent the vasogenic edema, which is one type of cerebral edema. And in that way, we can produce what is called a more uniform blood supply to the brain cells. So that's one principle. If you can read about the barbiturate coma, what would you put, do that or induce it for patients with TBI? That would be great. That would be great. Second, increase ICP. So patients with different types of neurologic diseases like TBI, stroke, brain tumors, infections, meningitis, all of these are risk factors for increased ICP. And we talk, and think we have in classroom we talk about the factors that may increase the ICP. So the first, the increased ICP and TBI. So what is that link between the TBI and increased ICP? As the blood capillaries leak in response to the injury, the brain tissue swelling occurs within the confining limits of the bony cranium. Remember that the cranium is a closed vault. It's a closed space. We have blood vessels and blood tissue, which is brain tissue, and we have CSF. All three components will compose or will form the ICP, the intracranial pressure. So that pressure within the brain tissue, it will rise, either because of there is a tumor, there's an increased blood supply, vascular volume, or because due to the stroke or due to brain tumors, and so on the like. So we have too many factors that may increase the ICP. Sometimes even a change in chemistry or ABGs or hypercapnia, increased CO2 in the blood. So any of these factors may increase the ICP, and that will compress the cerebral blood vessels and decrease blood flow to the cells. And this reduced cerebral perfusion will result in increased hypoxia, anoxia, ischemia, and cell death, means brain cell death. So that's why increased ICP is critical, because that could lead to brain death. Now, in there are different types of TBI. The most dangerous one and most serious one, when the patient develops the fracture at the base of the skull, that's called basilar skull fracture. And then we explained in classroom, I believe, that there are few manifestations in which that patient will exhibit these symptoms. It indicates the basilar skull fracture. One of them is battle sign, which is post-auricular ecchymosis, which is battle sign, which is the ecchymotic area or ecchymosis behind the ear by the mastoid process, and also raccoon, which is the ecchymosis around the eyes. Now, increased ICP, it will develop like at different stages. So from mild, moderate, severe. So there is something called crushing triad of increased ICP, in which that you'll find that there is systolic hypertension, bradycardia, and respiratory changes, SBR. So I don't think we have time to go over the pathophysiology or manifestations, but at least I'm going to highlight a few things. Systolic hypertension with a wide pulse pressure. So when you say systolic hypertension, means patient's blood pressure like on 180 over 90 or 180 over 80. That's wide pulse pressure. So we have systolic blood pressure with wide pulse pressure. Patient will have bradycardia and respiratory changes. That represents the Cushing triad and indicates an increased ICP. And the brain herniation may be imminent unless immediate action is taken. That's why it's critical that nurses identify, assess, and able to find these signs before it gets like kind of severe to the point that patient develops the brain death. So once we identify and find these signs, we take immediate action to reduce the increased ICP. The dilated and non-responsive pupil, if there is pupil dilatation or non-responsive pupil, that may indicate an increased, that may indicate intracerebral hemorrhage. So there is a hemorrhage within the brain cells or blood vessels within the brain. So that if there is dilated blood vessels, pupils, and or unresponsive or non-responsive pupil, that's an indication of a intracerebral hemorrhage and increased ICP. Now, at some cases or scenarios that we have to implement or do a craniotomy to treat the increased ICP or that TBI with increased ICP. So the indications for the craniotomy surgery, like for if there is a brain tumor, then that will be one of the criteria or one of the indications, brain tumors. So excision of the brain tumor will be one of them. Another indication for a craniotomy would be the removal of a hematoma. If there is like hematoma, either epidural, subdural hematoma, that will be also an indication to remove that hematoma. To treat the increased ICP, sometimes they do craniotomy to relieve the pressure when there is extremely high ICP. So these are like the three scenarios in which that sometimes we have to implement perform craniotomy for the patient. Let's take the first question. We have a few questions after each section. Okay, anyone can read it, please?
Professor, you're not sharing your screen. I can't see anything.
Oh,
Yes, you're not
I
sharing.
think you also have. Sorry for that. You told me this earlier, but you can easily follow me also on the PowerPoint slide I shared with you on Canvas.
Yes, now we can see it. Thank
Yeah,
you.
yeah. But you also have access to these slides, right, on Canvas,
It's
right?
on Canvas?
Oh yeah,
Yes,
yeah. They're on
Professor.
Canvas. Yes,
Oh,
they're on
okay. Thank
Canvas.
you.
Yeah, the same slide. Yeah, I have. Yeah, they're on Canvas. You can just go on Canvas under Exam Reviews, and it will be the last tab under Exam Reviews, Modules, Exam Reviews, and then you'll find the tab. So let's take the first question.
A nurse is collecting neurologic data on a client who has a neurological injury and notes changes suggestive of Cushing's triad. The nurse understands that Cushing's triad is a nervous system response that might prevent which of the following conditions? Is it A, brainstem ischemia?
Cerebral blood vessels adjust to changes in blood pressure through the constriction and dilatation of the cerebral blood vessels to maintain constant cerebral perfusion pressure. Remember that there is a system within um, it's a theory, but it's more a system that is govern the three components of the ICP, the blood in blood vessels or blood in the brain, blood vessels, the brain cells and tissue, and then the CSF. So the Monroe-Kennelly doctrine, it's like a doctrine that kind of govern the changes within the three components and try to maintain the balance and to maintain the ICP within range. That's intrinsic, natural, physiologic, on a doctrine, our body attempts to compensate, right? So, yes.
I had a question about that. So basically, it's one of the three components. So if one goes up, so the other gonna go down so that it balance it.
If there is one change in one component,
Okay.
the body attempts to change the other two to balance that change. So that's called the Kelly-Monroe doctrine. So it's a doctrine, again, it's the physiologic, natural, intrinsic, our body able to kind of compensate for the changes within the three components. So I know it's one of the difficult concepts in neuro, but at least just to understand that there are three components. Our body attempts to compensate when there's one change, like if there's an increased CSF. If we change position, sometimes one of the components will, alter or change, then the other two components will be compensating for that one. So again, it's the system that is going to govern the three components and maintain the ICP within range to some limit. So our body can at some point or able to compensate for the changes within the three components to a certain limit. And then after that, we will see the increased ICP. Like, for example, if it is like, brain tumor, small, tiny one, probably it's not going to show like increased ICP, but more than like, 2, 3, or 5 millimeters, then probably going to see more heightened and increased ICP, for example. And the other examples would be the same. Our body can compensate to a certain limit, but after that, it will show as an increased ICP. Okay, next question.
Professor, we have one question before this one.
One before. I believe did we go over this one? We said, yeah. We said the question.
Okay.
Yeah.
So sorry.
It's A. Yeah. The answer was A. Next question.
A nurse is providing care for a group of clients in the emergency department. Which of the following clients is at risk for developing neurogenic shock? Is it A, the patient who has GBS?
Yeah. You're reading the question. Sorry. Oh.
I have your PowerPoint open on the side, so that's the next question.
The next question. Yeah, you're reading the triad. Sorry.
No, yeah, Zena did that.
We answered this one.
Yeah.
We said the brainstem ischemia.
Yes, we said brainstem ischemia.
Right. Yeah, I didn't explain or provide some explanation about it. So the Cushing's triad include, we said, wide pulse pressure, bradycardia, and irregular breathing, right?
Yes.
Now this stimulates the sympathetic nervous system that would allow for an increased blood pressure and heart rate. So that would help with the brain perfusion. Okay. So the next one, he said, the answer was
A.
Why GBS, patient with the GBS, to be at risk for neurogenic shock. So we said that, I think we had the same question right in class, right? We said burn injury, they are at risk for what type of shock? They lose significant amount of fluid loss.
Yes.
So that they are at risk for
hypovolemic
hypovolemic shock. Patients with asthma attack, the asthma precipitated by the what? As an allergic reaction, IgE, allergic reaction. So the patient will be at risk for anaphylactic shock. Patient with chronic kidney disease, right? They are at risk for septic shock. They are at risk for septic shock. So GBS, why GBS? Because we said GBS, this patient with GBS at risk for developing neurogenic shock because both the blood pressure and heart rate are controlled by the autonomic nervous system. Remember that ANS, sympathetic and parasympathetic. So the client whose autonomic nerves, the autonomic nerves, the sympathetic and parasympathetic, they have been affected by the GPS and are at risk for developing the neurogenic shock because both the blood pressure and heart rate are controlled by the ENS. Okay, next question. Okay, volunteers for next question.
A nurse in an emergency department is caring for a client who had a seizure and became unresponsive after stating she had a sudden severe headache and vomiting. The client's vital signs are as follow: blood pressure of 198/110, pulse of 88, respiration of 24, and a temperature of 100.8. Which of the following neurologic disorders should the nurse suspect?
So let's just go to the answer first, and I'll explain about the rationale behind it. Seizures and became unresponsive after stating patient had a sudden severe headache and vomiting. So when you hear the patient saying that this is the worst case or worst headache I ever had,
That's hemorrhagic.
it's
It's
always hemorrhagic. Always
hemorrhagic.
will be hemorrhagic.
Yes,
When you see
severe
that,
headache.
when you hear a patient say, stating that sudden severe headache or the worst type of headache I ever had, that's always hemorrhagic shock. So the client who had hemorrhagic shock, they often experience the sudden onset of symptoms, which include the sudden onset of severe headache, a decrease in level of consciousness, and seizures. Hemorrhagic shock also occurs when bleeding occurs in the brain because the rupture of the blood vessels or aneurysm, sometimes like a cerebral aneurysm rupture because of the patient, sometimes super healthy. They have no history of any cardiovascular disease or even hypertension or any cardiac disease, but they have an aneurysm that hasn't been diagnosed. So aneurysm or undiagnosed cerebral aneurysm pressure will increase the increased pressure within the aneurysm, result in rupture of the aneurysm in the brain, and that results in bleeding, hemorrhagic stroke. AV or AV malformation sometimes in the brain blood vessels, like tangled small tiny blood vessels in the brain that results in rupture and hemorrhage. But I would say most of the patients with who develop the hemorrhagic shock, usually not just because of aneurysm, but most of them they have or have been diagnosed with hypertension, but either undiagnosed or untreated or undertreated, or patients non-compliant with medications. That's when they develop the hemorrhagic stroke, or sometimes trauma, like a traumatic brain injury or trauma, and result also in a hemorrhagic stroke. Next question.
A nurse in the emergency department is caring for a client who has a compression fracture of the spinal vertebra. During the transport to the facility, the client was medicated with intravenous morphine. On arrival, the neurosurgeon determined urgent surgical intervention is indicated for the fracture. Staff member have been unable to reach the client family. Which of the following actions should the nurse anticipate the neurosurgeon taking? I say A.
Why do you think A? So this is the question that has to do with the legal implications. Why do you think whichever it's A?
Because the client most is impaired and most likely cannot make that decision.
Yes. At its critical condition or emergency situation here. So the neurosurgeon has the legal right to invoke implied consent and proceed with the surgery if it is determined, or the team and he determined, or she, an emergency, and surgery is in the patient's or client's best interest. So the neurosurgeon should document the specifics of the situation and the patient's medical record and go ahead and perform the surgery. Delaying the surgery until, again, that's going to place the client at risk for poor outcomes, health outcomes. Therefore, this is not the action that we should anticipate. The client, or ask the client to sign the surgical consent form, we shouldn't, or the neurosurgeon shouldn't be asking the client to sign the form because patient is sedated from the morphine. So patient is, I just mentioned, is that patient is impaired. Either patient is disoriented, patient unable to function because of the administration of medication like morphine, or patient is, is impaired. So the prescribing naloxone to reverse the effect of the morphine. Now, the purpose of the naloxone is to reverse the effect of opioid toxicity, not the morphine itself. As medication prescribed and given, but there is a reason why we give it to the patient for pain management. But naloxone, when it's being prescribed or when it is prescribed, it should be prescribed to reverse the toxicity of the opioids, like morphine, but not to reverse the effect of the morphine itself. Okay, so the nurse is caring for a client who has increased ICP and has worsening neurologic condition, which the following cues should the nurse recognize as worsening condition. And here we are going to list all the manifestations, and the patient would exhibit for an increased ICP. And the required assessment techniques to be done to find out if the patient has these symptoms. So manifestations and techniques. When we do the glaucoma scale, should you expect decreased GCS scores? And remember that the highest is 15 and the lowest is 3. I mean 0, but we will start from the lowest 3, like one for each one of the 3 components. So decreased GCS, would you expect decreased GCS in patients with increased ICP? Remember that the 3 components of the GCS are pupil reaction or response, right? What else? GCS, when you do the glaucoma scale.
Motor response and
Motor response.
verbal response.
And verbal response. These are 3. So what do you expect? There is an increase, or the increased ICP to be to expect low or decreased GCS scores?
It will decrease if
Decrease.
Yes, absolutely. There should be a decrease. Some, like, decline, but not to the significant point that patient will be unconscious, right? So there will be a decreased GCS scores. Would you expect changes to pupil size and shape?
Yes.
Dilate.
Yes. Changes pupil size and shape, and then swelling the optic nerve, which is called the papilledema.
Papilledema.
Yeah, papilledema. That's expected as well, right? So we have A, B, and C.
And C.
What about blood pressure of 108/74?
It's within normal range. So that's...
Yeah, we expect that patient to have a wide pulse pressure, especially with systolic hypertension. Systolic, wide pulse pressure. So we have A, B, C only. What about respirations of 12?
That's normal.
It doesn't see a regular breathing pattern. It's not. So we exclude that as well. Then apical pulse of 82, no, because patient usually with increased ICP, they have brady or tachycardia.
Bradycardia.
Bradycardia. That's why. So we have only A, B, and C. Okay. Next question. Nurses caring for a client following surgical treatment for a supratentorial brain tumor, which is the following interventions should the nurse take? What do you put patient? What about passive range of motion exercise to the neck?
Is it because you don't want them to move their neck too much so that can increase the ICP?
So this one you should not be doing, right? So
Yes,
which of the
so is
following
it
exactly? So exclude that because of this, because that's going to increase ICP. So extreme neck and hip flexion, neck flexion and hip flexion can increase the ICP. Even hip flexion. Okay, neck and hip flexion both. Because remember that the hip flexion is going to increase intra-abdominal and intrathoracic pressure. So head should be kept like a midline neutral position. Now C, place the client in a flat lateral position.
No.
No.
I think for
Why?
the
that's for
for the infra is for flat.
Yes. So avoid placing pressure because that will also put pressure on the incision site at the back of the neck and on the surgical site from the higher brain structures. Notify the provider for drainage greater than 80. No, we will go by that the nurse should notify the provider for drainage or off drainage greater than 50 mLs in 8 hours. So more than 50, not 80, because this can indicate a CSF fluid leak, which requires the surgical intervention. So the answer is A, because that's the head of bed elevated to at least 30 degrees, can go up to 45, fine, but at least 30 degrees because the client who has surgery to be treated or to treat the supratentorial tumor is at risk for increased ICP. So the elevation of that up to like at least 30 degrees would assist in promoting the venous drainage from blood vessels by gravity and CSF fluid drainage from the head to prevent increased ICP. So by gravity, that would increase the drainage from the brain blood vessels and CSF as well. Nurses caring for a client who has suspected brain tumor, which is the following diagnostic test, should the nurse understand is most frequently used to diagnose brain tumors. So blood tests for tumor markers. Pancreatography, which is endoscopic cholangiopancreatography, ESRP. And then we have FOBT, which is fecal occult blood test. And the last one, CT. And you can also D to include CT and or MRI. Which one? CT,
CT.
right? Yeah,
Yeah.
good. CT. So we know that the tumor markers, like when you do the AFP for liver cancer, AFP, for example, that's tumor marker for liver cancer. When we request the BRCA1 or BRCA2, that's for breast cancer. We can request also tumor markers. There are, for each like the type of cancer, there is specific like tumor markers. The PSA is like a prostate cancer marker, tumor marker. So the tumor marker is not an answer here. And because tumor markers is commonly used to diagnose various cancers, including the prostate cancer, liver cancer, colorectal cancer, and breast cancers, and others. Now, ERCP, we learned from the GI, is that the ERCP or cholangiopancreatography. That is a technique or test or diagnostic test to diagnose the GI, either that's pancreas or liver or either one. But this is GI. Couplet test also, that's usually done for C. diff. We do it for GI and peptic ulcer disease, but not tumors. The only one is CT, and we can add also MRI, or if you replace CT with the MRI would be also the correct answer. So we understand that there are two types of imaging tests that they are frequently used to diagnose patients with brain tumors. Either we do the CT, and sometimes we do MRI, or even we do both at times. So that covers the brain tumors, increased ICP, and now the GI. GI, I think we spent a good amount of time in class talking about the diverticulosis versus diverticulitis and the recommended diet. I think when we spent, also we went over some of the questions, answering like the concepts, the concepts of the GI, especially this content, and we identified some recommendations or that not recommended or should be avoided or restricted. So like food high in fat that can because it will increase peristalsis. So high fatty food, that's not recommended for patients with IBD or diverticular disease because that will increase peristalsis. The dairy products and fruits that can also irritate the bowel, fruits and dairy products should also be avoided to some extent because that also will irritate the bowel. Peanut butter also and whole wheat bread, that is because of the high residue, that also to be avoided. Now, patients with acute diverticulitis, if at times, so sometimes we, especially with the exacerbation or acute attack, will be admitted to the hospital with, an NPO and they'll be on fluids, and they will have at some point NG tube. Not all of them, but if need be. So at some point they will have the NG tube. So we expect that the drainage from the NG tube to be green bile. The green bile drainage from the NG tube is expected in patients with acute diverticulitis because they are NPO. They have the bile secretions coming out and be drained through the NG tube. So that's expected. So it's not unusual to see this in patients with NG tube while they are, being admitted with NG tube and admitted with acute diverticulitis. Now, diverticular disease and IBD also, so patients with acute episode of the diverticular disease or IBD, like either ulcerative colitis or Crohn's disease, they will be at risk for peritonitis. And we learned about the signs and manifestations of peritonitis and renal like hemodialysis and peritoneal dialysis. And we said that the abdomen will be like, a hard, rigid-like abdomen, rigid, hard abdomen, elevated temperature. All of these are indicative or indications of a peritonitis. So, which is an acute post-op complication of abdominal surgery. Sometimes patients with IBD or diverticular disease will undergo surgery, and then post-op, if they develop any of these manifestations, also that would indicate that the patient had developed peritonitis post-op. So either during the disease process as an acute episode, or at some point when they post-op after like hemicolectomy, after the surgical intervention, after for that disease process, they will undergo surgical intervention, and then the post-op, if the patient exhibit any of the previously mentioned or aforementioned manifestations, these will be that will be an indication of peritonitis. So, which requires an immediate intervention. And again, the most obvious and easy assessment finding is the abdominal rigidity and a hard abdomen, board-like abdomen. That's a sign of peritonitis. Hepatitis, I have a good number of questions about hepatitis, and also when there is a presentation, and we also explained in class about the different types, A, B, C, and other, and the difference between them. It's critical that we know that the type A hepatitis, it's a fecal oral route, and the other types are, especially B and C, they are a blood-borne, and they transmit through the bodily fluids, especially the blood. The liver cirrhosis also, we went over this and spent a good amount of time in class talking about the manifestations and treatment and nursing care. Tips, surgery, which is used to lower the pressure in the portal venous system and decrease the risk of bleeding from the esophageal varices. Patient will liver cirrhosis, they tend to develop a complication called esophageal varices, and the tips would be one of the interventions, like surgical interventions, to treat the complication and to lower the portal hypertension and to lessen the pressure within the portal vein, which also eventually is going to treat or prevent the esophageal varices, or at least to lessen the intensity of the esophageal varices in terms of the bleeding, which is and hemorrhage associated with esophageal varices. The tip surgery, it doesn't affect any of the findings, like, for example, ALT, EST, or bilirubin levels, or serum albumin or globulin levels. They will never be affected by the TIPS surgery, but the most important outcome from performing the TIPS surgery is which is more of shunting, is to lessen and decrease and reduce that risk for bleeding from esophageal varices, because we will lower the pressure within the portal vein and decrease the portal hypertension. So, and the tips will increase the risk for the tip surgery is again, so is going to reduce the portal hypertension. Now, liver biopsy. The liver biopsy post testing or post liver biopsy test, the client should be placed on the affected surgical site, which is the right side of the abdomen. Can be for a couple of hours, less or more, but around like 2 hours following the biopsy. And that will create like pressure on the insertion site or the incision or the puncture site, because the liver is a highly vascular organ. And again, if we don't implement pressure right after the procedure for around like 2 or 3 hours, that could lead to a hemorrhage. So part of that would be, how do you indicate that there is internal bleeding? Because internal bleeding, patient, there is no blood, obvious, like, blood coming out of the incision. So the internal bleeding will be indicated by vital signs, hypotension, and tachycardia. These are 2 indicators. That's why, so vital signs post liver biopsy, it's required, it's critical to be performed and done, because that will provide us with some findings and indication, or will provide like clinical picture of a patient if they have internal bleeding or not. So it can detect internal bleeding. So the ammonia. Also in classroom, we went over the ammonia in terms of why ammonia will be elevated in the blood, and what are the medications that are very effective to treat the high ammonia level. and the ammonia, high ammonia level in the blood result in a brain or encephalopathy, and patient to start have a behavioral alterations due to that increased ammonia level. And the read about the lactulose, rifaximin, and the purpose of the lactulose and or rifaximin in patients with cirrhosis is to lower the ammonia level to prevent the encephalopathy. And the most important concept associated with encephalopathy or prevention or treatment of the encephalopathy is to lessen the not just the behavioral alterations and changes, but also for safety precautions or safety measures. So we have to institute the safety precautionary measures or precautions to prevent the injury and prevent the trauma to the patient due to that encephalopathy. Also, remember that patient with a liver cirrhosis, they will be at risk for bleeding due to the decreased production of clotting factors. So the elevated PT and INR and elevated also APTT, they are all indications of clotting disturbances, and that may alert us or the nurse to the increased risk for bleeding. So from liver cirrhosis, look at the clotting factors, PT, INR, PTT. Elevation indicates there is a clotting disturbance and there is a high risk for bleeding. So we would know that the patient will be at risk for bleeding from these three measures. So that's where we, that the concept here is that we have to make sure that we are within range. Otherwise, we have to do something about it. Like sometimes we give clotting factors IV to the patient to replace the loss of these factors and prevent the bleeding. Like fresh frozen plasma usually is the best intervention for patients with liver cirrhosis, fresh frozen plasma, because we can deliver and administer the clotting factors to the patient immediately within that fresh frozen plasma. Portal hypertension and esophageal varices. The portal hypertension that accompanies the end-stage liver cirrhosis would predispose the patient to the esophageal varices and resultant hemorrhage, which is hematoemesis. So these varices, when they rupture, there is an increased, due to increased pressure, coughing, sneezing, increased abdominal pressure, positioning, all of that will result in the bleeding from these varices. The portal hypertension increases the pressure in the venous system and contribute to the development of esophageal varices. So the esophageal varices are a resultant complication from the portal hypertension. Now, patient will have an intervention called for a balloon, which is like one of them is the Singh-Stankin Blakemore tube, which has the two balloons, the one for the esophagus and one for the stomach, and it will create pressure against the esophagus, will prevent and will stop the bleeding. So the most common complication of balloon, so balloon tamponade, remember that we said that catheter, it's not widely used or commonly now used, due to its the complications associated with it or the risk of the airway obstruction associated with the balloon. So you will find that very few who would recommend the balloon. But again, because our books still have it, the board exam, you may expect a question in the board exam about it. So that's all you have to cover it. So the balloon tamponade, the most common complication of the balloon tamponade is aspiration pneumonia. So in addition, if the gastric balloon ruptures, so the first one, number one, aspiration, so airway obstruction, aspiration, and then aspiration pneumonia. Number two, the risk factor associated with this or the complication associated with balloon tamponade if the gastric balloon ruptures, remember we have esophageal balloon, the long one, and we have the rounded one, the gastric balloon, two balloons. So if the gastric balloon, the round one ruptures, the esophageal balloon may slip upwards and occlude the airway and result in airway obstruction. That's another reason why some practitioners do not recommend the step balloon. However, our job is to make sure. So let's say so anytime you have a patient with this type of balloon, and again, one of the most common ones is called the single-staken Blakemore tube. Read about this and in my PowerPoint slides in the book, you'll find a good coverage. So the balloon, one of the things that we when you review about the balloon or read about it, you will find that the balloon should be deflated every 8 to 12 hours. Otherwise, if you continue to inflate or the balloon inflated for good or for a week or two or more, longer than 12 hours, that will put the mucous membranes at risk for necrosis. Similar to when we went over the endotracheal tube, the ET tube, we have like ET tubes with two balloons, and alternatively, we will inflate one and deflate the other. Same thing here. We have only two balloons, either both deflated or inflated together. So the esophageal balloon, not the gastric, just the esophageal balloon, because the gastric is against the sphincter. The gastric is inflated against the cardiac sphincter. But the esophageal, the long one, it's against the esophagus, and it can result in esophageal necrosis. So this esophageal balloon should be deflated every 8 to 12 hours to prevent the risk for necrosis. There are other complications associated with liver cirrhosis. One of them is asterixis, which is also, we said that asterixis, which is the flapping tremor. That flapping tremor, you will find it in both patients with liver cirrhosis as well as in patients with end-stage renal disease, ESRD. Here, each one has a different mechanism, but both affects the brain. So the asterixis here and this liver cirrhosis indicate that the patient has hepatic encephalopathy. It indicates an advanced stage of hepatic disease, which is hepatic encephalopathy, has developed, and hepatic coma may, eventually occur. So, in other words, that when you see asterixis, it's not a good sign. Which means it's an advanced hepatic encephalopathy in which that it's an imminent, or patient may have an imminent hepatic coma. The spider angiomas, these are the tiny blood vessels in the right upper quadrant of the abdomen, and that due to the inability of the liver to metabolize some hormones like estrogen. We went over the ascites and the weight gain. We have to have monitor these two findings because they indicate the need for treatment, and especially in patients with liver cirrhosis here is that they tend to have different levels of ascites, and the weight, the daily weight and the abdomen should be. We need to do what is called a daily abdominal girth, which is the measurement of the circumference of the abdomen, and we have marks on the abdomen, but with the Sharpie with the permanent pen, marker, so we can do the same measurement or using the same marks every single day. So every day in the morning, we will at the same time before breakfast, for example, we have to control some of the factors like before breakfast, in the morning. If we can stick to these measures, so we can eliminate some of the confounding factors that may change or alter the the results. So if you can have same marks around the abdomen. So you can use them every day you can use the same marks when you do the measurement. Same time, before breakfast, or so you have some type of rules, some type of conditions to be controlled. So you have or this can yield a valid, reliable results or findings. So the patients also with the liver cirrhosis, we include, so let's go over the esophageal varices treatment. There are different levels and different times and different classification of treatment for esophageal varices. One of them is beta blockers. The beta blockers for patients with esophageal varices, because it will decrease the risk for bleeding from these varices. So beta blockers will be number one. Doesn't mean like it's the best, but at least should be included in the plan of care of patients with esophageal varices, because the decrease of blood pressure within the varices will decrease the risk for bleeding. Second, they do something called banding or O-ring or banding. They inject also medications like octreotide, Sandostatin. So read about the esophageal varices and the treatment modalities to treat esophageal varices. The liver transplant. Now, you will read about the indications, about the complications associated with that, such as rejection, and the management of the rejection. And one of the questions in the hotspot questions was about the patient was actually the kidney, not the liver here. So the question was that's exam number 2. Hotspot questions in which that patient developed some complications during I believe, week 2 or 3. So at this point, what we can do is that we can double or increase the dosage of the immunosuppressive agents, not doing the hemodialysis or remove the organ or transplant a new one or do anything else. It's just to double or increase the immunosuppressive agent. So that's will be number 1, or the first intervention or the first salvage for these complications or manifestations that patient presented or exhibited a few weeks after the transplanted organ. So that applies to a heart, cardiac transplantation, kidney transplantation, liver transplantation. It's the same concept in which people develop the complications or manifestations, signs of rejection post few days, few weeks after transplantation. The number, so first thing is that we're going to increase the dosage. So the increased risk risk is high in the first few months after the liver transplanted or transplantation. Fever is elevated temp is frequently the only sign of infection. So the immunosuppressive agents or therapy, which must be used to prevent and treat organ rejection, significantly increases the patient's risk for infection. And we been covering the same concept since day 1 of this class, is that read about the high risk for infection, what are the techniques and measures and things that we have to implement as precautionary measures to prevent the infection. In the early post-transplantation period, common infections include pneumonia, wound infections, UTIs. Post complications of liver transplantation include bleeding, rejection, infection. So although the rejection, it's not as more, I would say a significant or major problem as it is for kidney transplantation, there is a risk of immunosuppression. So rejection in kidneys are way higher than the liver transplant organs. So rejection is, in terms of the prevalence and the risk for rejection, it's been recorded as to be highest in kidney more than the liver transplant. Then also remember all the measures that we covered in other organs, like the public areas like the swimming pools, the spa, the tattooing, piercing, for because of the infection risk for infections, the toxoplasmosis infections, like playing with sand on on the beach, or all these are, or the stagnant water, like any flowers in a vase or vase. All of these are examples of risk for infections in patients post-transplanted organs, and we have to be careful to educate the patient about all these like specific possible reasons and risk factors, so they can avoid patients with large crowds or heavy crowds and patients, and like all these are examples of techniques and precautions to be taught to the patient. The crucial role of the nurse also in long-term follow-up of the liver transplantation is to make sure that patient is compliant with the immunosuppressive agents, because this tend to be one of the most tedious, serious, and patients tend to stop or become non-compliant, not completely not taking the drug, but non-compliant with the medication because they will be on too many meds, sometimes 4 or 5, just immunosuppressant agents on a daily basis. So we have to stress the importance of and encourage that the drug compliance or medication compliance. The patient takes the drugs every single day, especially these immunosuppressive agents. So the last content or topic here in this content is the pancreatitis. Either it's acute or chronic. Acute or chronic. In acute pancreatitis, the client should be kept in the acute phase of the disease, like of the acute pancreatitis. Patients should be kept NPO to reduce the GI activity and reduce the pancreatic enzyme production. Pancreas produces enzymes in response to the presence of food in the GI. NPO, that's number one, or first intervention, or first step to prevent the secretions of the enzymes by the pancreas. So also IV fluids should be used to prevent dehydration, because one of the most significant manifestations of this disease is dehydration. Patient NPO, that even make it even like more heightened and worse. So that's why we have to do a good IV fluid replacement. So when food is then eventually like patient will be maybe like NPO for few days, 3-4 days, and then we will introduce food or fluid, and then so the process is that when food is patient become tolerant, or the GI tolerates the food during the recovery phase, then we should prescribe. So eventually patient after 3 days or 4 days, patient will be like liquid diet, and then we gradually increase the consistency and the frequent and the amount of or the quality of food until the patient will be on a small frequent meals. The meal should include moderate to high carbs, protein high, fat low. So they'll be on small, frequent, moderate to high carb, high protein, low fat meals. We can introduce or include some spices, but should be bland with very little spices. But bland diet is the best. But if they want to include some spices, that's fine. Should be very small, tiny amount of spices. The things that should be avoided here about patients with acute pancreatitis. So the GI stimulants like caffeine-containing foods, tea, coffee, cola, chocolate, all of that, as well as alcohol, should be avoided. Now, the primary diagnostic test for acute pancreatitis, you will find elevated enzymes. Remember that, make sure that, whenever you see an elevated ALT and EST, sorry, that's for liver, sorry. The elevated lipase and amylase, so elevated EST and ALT, alkaline phosphatase, bilirubin, that's for the liver, right? So for pancreas, whenever we see elevated lipase, elevated amylase, these are two enzymes secreted by the pancreas. But remember that also in saliva, we have some amylase. So that's why the lipase is more determinant than the amylase, because there are other organs or tissues that would produce the amylase. But both elevated indicates or should to rule out the pancreatitis, amylase, and lipase enzymes. So serum amylase, serum lipase elevation indicates pancreatitis. So the serum amylase level is usually elevated early, the amylase, and remains elevated for 24 to 72 hours. The serum lipase is also elevated in acute pancreatitis. It's an important test because other disorders, like other disorders like mumps, cerebral trauma, renal or kidney transplantation, you'll find also some elevation in the serum lipase. But eventually, just to sum this a little confusing, maybe like think about the testing about the enzymes, liver enzymes, is that I'm sorry, pancreatic enzymes. Whenever you see an elevated EST and ELT, that's an indication. Again, I'm sorry, an elevated amylase and lipase, amylase elevation, lipase elevation, both indicate acute pancreatitis. Now, also patients with pancreatitis, at some point, they may have an NG tube with hooked or connected to the suction. So patients with NG tube or with acute pancreatitis and have the NG tube, there will be NPO. So the NG suction and the NPO status, that will decrease the release of the enzymes. Again, we said that we have to rest the bowel and the pancreas. So NPO and the NG tube suction, that will release the pancreatic enzymes into the pancreas and decrease pain. So it will rest the bowel, rest the pancreas, and also it will decrease pain. And in addition to that, what we just mentioned about the treatment, pain management, NPO and suction and fluids. Also, so electrolyte level should be assessed, and to make sure patients' electrolyte level, sodium, potassium, and other electrolytes, that should be within range, and especially with the NG suction. With the NG suction, patient lose more of the sodium as well. So we have to make sure that whatever being lost is being replaced by appropriate IV infusion. Patient not becoming to prevent hyponatremia, we have to replace the sodium, and that would apply to also other. So we have to do a electrolyte profile, or electrolyte level should be assessed, and to lead us or to guide us for the best treatment to prevent any of the electrolyte imbalances. And the next slide, which includes the last slide, will have or include the medications that you have to review. And there are a few questions here about the liver, pancreas, and diverticular disease. Okay, so this question, the nurse educates the client recovering from acute diverticulitis. And I believe that we answered a question very similar to this one in class. effect. So the nurse evaluates the teaching has been effective when the client makes which selection for lunch? Which of the following selection for lunch would be appropriate to a patient with acute diverticulitis? And we said that patient with acute diverticulitis should be on high fiber diet or low fiber diet.
High fiber.
Diverticulitis.
Low. Is it low to reduce GI
I
function?
thought we said
It's high fiber.
I thought we say high fiber in class.
Mhm.
High
Yes.
fiber. Hold on.
Yeah. So it's the concept. The concept here is that about the diet and disease process. So acute diverticulitis. It should. The question is: the nurse evaluated the teaching has been effective when the client makes the which menu? Okay, so which one is best for a patient with acute diverticulitis?
I think B.
Do you remember in class we had a good number of questions around acute diverticulitis and diverticulosis?
Um,
And
I
we
think
said
I think
during
you
the
I
during
think he's
diverticulosis, is it high fiber diet or low? Diverticulosis means during the regular, I would say like, it's the absence of acute episode of the disease process. It's like remission phase.
Professor,
Acute is exacerbation phase. Go ahead. Yes.
I think you mentioned that you start with lower fiber diet, and then once like it's tolerated, like the
N-
inflammation
Well, we have two different
dissolves.
scenarios. We have a patient with diverticulosis when they develop the acute attacks, flare-ups, attacks, exacerbations, and most of the time they will be admitted to the hospital. That is acute diverticulitis. And a daily, normal, like, daily living or daily life, they will have, they kind of adapt to the
So,
disease and live with the disease. That's diverticulosis. Acute attack, that acute diverticulitis.
so that's I'm confused.
So we have diverticulosis versus diverticulitis.
So it's high fiber during the acute stage.
Mhm. Yes.
Because we said because first we have tech if we have text 2 and low fiber, isn't that gonna pressure like build up the pressure and it's can rupture?
No, I think we went over, in class we have we have a good number of questions, and there was presentation, and we said we have diverticulosis and diverticulitis. Diverticulosis, low fiber diet. A diverticulitis, that's the acute phase of the disease process. So A is the whole wheat bread and the raw fruits and vegetables that are food that are high in fiber content.
Okay. Okay, I think I get it now.
Yeah, right. So just read about the difference between diverticulosis and diverticulitis and the fiber content. That's most of the time it's always confusing, but make sure that you get the diverticulosis, low fiber, diverticulitis, high fiber, and most of the questions will be around that. Around this like concept. Okay, next question. Patient admitted with a tentative diagnosis of acute Hep C, the nurse determines that which client statement would be most consistent with the diagnosis. Hep C.
Is it dizziness and ringing in the ears?
What it has to do with Hep C? Is it one of the manifestations of Hep C? So for this question, thinking about the signs and symptoms associated with hepatitis is necessary to analyze the client's statement and eliminate options. I mean, this question is purely can be answered by, with the technique or the skill of elimination. So even though that we did not cover anything has to do with like the manifestation of C and smoking or tobacco, but that's the only way to answer it. So the process of elimination can also be used to eliminate so A and B. So C, nothing to do with the disease, right? With Hep C. You can eliminate also A and B for the same or using the same technique.
So it
Then you end up with D. D, yes. This next one is a question.
Professor, do you mind explaining D? Why it's D?
Because of tobacco and effect on the liver and all the more than the good number of chemicals that will affect the liver and result in hepatitis. Not necessarily all the tobacco, like smokers, like tobacco users, are end up with this, but at least it's one of the risk factors. It's one of the risk factors. So there is a history of tobacco use. So that would indicate even the patient stated that they can no longer tolerate the taste, but at least patient has been using tobacco for a long time or for a while for some amount of time. So there is a history. So that history indicates that there's a link between tobacco and Hep C. Patient assignment, and which that you have 4 patients and you have a limited number of rooms, or you want to put them in or assign them on the unit. How would you put them all, like 2 in each room, or one in private in each, like one in a private room, or all of them, like each one in a private room, or 2, whatever. So what is the best assignment for these 4 cases based on the diagnoses? And most of these questions, or questions similar to this one, has to do with the cross-contamination. You have to, you need some knowledge about the precautions, or like the isolation techniques, or what type of transmission for that disease, or transmission mode of transmission. The mode of transmission is a very critical concept here. Is that airborne, droplet, contact, neutropenic?
Professor, is it B?
How would you explain
Is
that
it
it's
because
B?
client C, who's client number 3, has
Yes.
airborne precautions and night sweats. So would they have TB?
Yeah, sorry, this one should be client 2. Sorry. Yeah, this one is client B, right? Which
No,
is
I meant
2.
letter B. So like client C.
Oh, B.
Client C.
Yeah, client C gets a private room. And then clients 1 and 4 get the same room because they both have MRSA. And then 2 and 5.
Yes, B is correct. Yes, because the client C has airborne precautions and patient requires a private room, right?
Yes.
Now, client A and D, which is client A and
1
D,
and
one or
4.
1 and 4, yeah, 1 and 4, they have the same
Because
organism. They have MRSA and MRSA.
yes,
So you can put 2 MRSAs in the same room, same infection.
you can, right?
Yeah,
Yes.
same infection. Nothing wrong with having 2 infections, or 2 patients with same infection, like 2 MRSA cases, yes, in the same room. Um, the and 2 and 5, 2 with Hep C, and 5 post-op hypo. I'm sorry, post-op small bowel resection and hypotensive. So Hep C and post-op 2 and 5 in the same room. Yeah, you can. So we got that one. 1 and 4 because they have 2, right? They have the same organism, MRSA. They both can be roomed together because both require contact precautions. MRSA and MRSA, the same organism, same room, same contact precautions. Now, second patient or patient 2 and patient 5, patient with Hep C and patient who is post-op, they can also be roomed together because both require only standard precautions. They don't need any other specific type of precautions like contact, airborne, and others. Um, Hep C transmission occurs mainly because sometimes people would think that Hep C was a isolation or precautions. No, Hep C, the transmission of Hep C occurs mainly by contact with blood, and this addressed with the any disease that is transmitted through the blood requires only standard precautions. Now here, a question um, about a patient who's been hospitalized and has a history of ongoing IV drug use. And when we did the serology, this is the result of the serology testing. You make which of the following conclusions? So this is about the hepatitis. It's a good question to review the hepatitis. The Hep B, it's about the Hep B, hepatitis type B, service antigen. Would the B service antigen normally, so normal values, would be negative or positive? The Hep B service antigen. The presence of the antigen in the blood, is it, when it's positive, is it normal? The antigen for Hep C service antigen. Normal value is supposed to be negative.
Yes.
So Hep C service antigen is supposed to be negative. Now the anti-Hep B immunoglobulin, the Hep C cell, which means the hepatitis B cell, the immunoglobulin type M. The immunoglobulin type M supposed to be negative. Now so we have the surface antigen positive, the immunoglobulin antibodies type M, they are positive. And remember the type of the two different types of immunoglobulins. The one that is during the acute attack or acute hep or having acute hepatitis versus the patient with the chronic hepatitis or who have received the immunization, right? So read about the different types of IgM and IgA. Immunoglobulin type A, immunoglobulin type M. Now, the IgM here is supposed to be negative, but for this patient is positive. Now, the AST supposed to be between about 8 to 38, but this patient has an extremely high AST. ELT supposed to be between 10 to 35, but this patient has an extremely high ELT. So elevated AST, elevated ELT, positive immunoglobulin type M, and positive B surface antigen.
So it's A.
So the answer is
A.
why?
I mean, it's hepatitis B. Oh, hold on. Let me put
Yeah,
my
that's correct. That this patient most likely has patient contracted hepatitis type B. The immunoglobulin type M is responsible for the primary immune response. So when the patient develops acute attack, then the immunoglobulin type M starts to rise as an antibody to respond to the infection. So the presence of the IgM, it's positive, indicates the acute infection. Later on, let's say 5, 6, 7 years from now, you won't find the IgM. You find a different type of immunoglobulins, type A. If you find them, you will know that patient has been infected or patient had received the immunization. So let's stick with this. We have an elevated IgM, which indicates the patient has acute infection, acute immune response, primary immune response, because we have two immune responses. One is primary during the acute attack, and one comes later, few months, years after. That will be indicated with the elevation of IgA, and that's i.e. secondary immune response. So this is a primary immune response during the acute attack, during the acute infection. We have an elevated IgM. So in this case, the positive IgM plus the positive antigen, the hep surface antigen, both indicate the acute infection and with hep B. However, that the elevated ELT and EST, that indicates the liver cell injury and acute infection. So at the same time, because that affects the liver, and the liver enzymes are ELT, EST, and alkaline phosphatase and bilirubin. I'm pretty sure that if you look at the bilirubin and the alkaline phosphatase also will be elevated. So elevated ELT, elevated EST, elevated alkaline phosphatase, and elevated bilirubin, all being elevated. That indicates that the liver has been injured. Hepatitis as an injury to the liver. So transmission of the hepatitis B virus that would occur through the contact with infectious blood or other body fluids. And all we have to do is to implement these standard precautions. So later on, when you see an elevated IgA, for example, in the future, that would be an indication of the immunity. Patient had developed immunity against the hepatitis, either through with the type A. Most likely, patient will usually they do not seek medical attention or receive any medications, but they develop the immunity against the type A, hep A. Hep B, they need the vaccine. So when they get the vaccine, an elevated IgA indicates that patient has been immune or developed immunity to hep type B. So answer is A, and it's not B because B, there is no indication of immunity to hepatitis B in the lab report, in our results, and the transmission can occur through contact with infected blood or body fluids. The C, the lab tests for the antigen and the IgM, which is antibody, both indicate that the client is being tested for Hep B, not Hep A. Because remember that Hep A is totally different from Hep B, because Hep A is fecal oral route in terms of the mode of transmission. And D, the antigen and immunoglobulin type G, if I mentioned earlier immunoglobulin type A, it's actually type G, it's not A. So we have immunoglobulin type G and I and type M. IgM, it's an indication of acute hepatitis, and IgG, immunoglobulin type G, it's an indication of chronic hepatitis. So those who have received the Hep B vaccine, they will their body, serology test should indicate and prove that they have an elevated IgG, immunoglobulin type G. In other words, or people have been infected and previously, later on they will have IgG, or people who had received the vaccine, they will have elevated IgG in the future, because that's an indication of immune response has been effective, or which means that they have been infected with hepatitis and their body developed immunoglobulins type G, or that they received the vaccine and they developed the immune reaction and they develop the immunity against the disease, and that's, again, it's an elevated immunoglobulin type G. So to summarize this is that IgM indicates acute hepatitis, and an elevated IgG indicates chronic hepatitis, or patient had developed, or individual had developed immunity against hepatitis. Client recovering from acute pancreatitis, so is an PO. Patients asking, when can I restart eating again? The answer is
Is it B?
Is it
When the
D?
vowel sounds are active?
so A, regaining appetite is a positive sign, but it must be associated by a decrease in pain before the client is allowed to take or ingest any oral food orally. So before they get anything PO food, the pain should subside or should decline as an indication of the disease process has improved. B, the intestinal peristalsis, it may be slowed or becomes like slower due to inflammation associated with acute pancreatitis. But the return of the bowel sounds and the pass of gas is not used to determine when the client can begin eating orally.
B.
Now, that's for B. I'm explaining about B. Now, C, once pain is controlled and the serum enzyme level begin to decrease, then the client can begin oral intake, and all, because these are signs of that the pancreas is started to heal. So the healing process for the pancreas is indicated by two things: pain level has been under control or declined to the lowest level. Second, that the enzymes has been or began to decrease. So low enzymes and pain relief or decline in pain level, two main indications to start PO intake, because these are indications of pancreatic organ or pancreas healing process had started. And there is no specific time for like how many days, how many weeks patient should be NPO. It's very specific to the patient's status, health status, and disease process, and the complications and how patient respond to treatment. So there is no specific time for how long patient should be NPO as part of the therapeutic management. So D easily can be excluded. So the answer is
C.
C. Yes. The client who has chronic pancreatitis is concerned about pain control. So which plan for the should the nurse explain to the client about the pain control for this disease?
Professor, I have a question for the
Yes.
previous question.
Yes.
Because for the pancreatitis, you mentioned two enzymes, which is lipase and amylase,
Yes.
and that's why it kind of like didn't made me choose to C because it only mentioned one. Does it matter?
Yeah. We said that. Remember, we said that we have amylase and lipase. Lipase is more determinant to the pancreas disease process than amylase, because we have other organs produces amylase. We have amylase in the saliva.
Okay, that makes sense now.
Lipase is more determinant of the pancreatic function than the amylase, but you always include both. But if you hear or see lipase, lipase enzyme definitely has to do with the pancreas.
Okay, thank you.
Mm-hmm.
I think it's C, Professor.
C, right.
Yeah.
So yeah, because the opioid analgesics,
We
why
say
do you
number
think C? Why C?
because we say I was doing elimination of process. We say number 8, morphine is not preferred, but Demerol. I think we said Demerol is preferred, not morphine.
Oh yes, absolutely. We said that there are
Yeah.
it's an old kind of topic and concept, that the morphine usually and it's not actually because of that, it's not the only rationale, but we in patients with pancreatitis try to avoid morphine because morphine is one of the opioids that is going to all the opioids, by the way, especially the morphine. Morphine, it will cause a spasm, result in a spasm of the sphincter of Oddi, which is the entrance of the pancreatic duct, and that spasm of the duct will result in it will extenuate, it will make the disease even worse. It will increase the intensity of the disease process and make it even more severe. So the opioid analgesics may be prescribed initially for pain control, but patient may develop dependency. So I usually we try to avoid morphine, right? For two reasons. It's first is going to patient will develop physical dependency, and also morphine will make that spasm for the pancreatic duct. The NSAIDs like ibuprofen that may be used to treat chronic pancreatic pain, but they are not the initial treatment, and they are usually not sufficient to control pain
And
for
it's
this patient.
receptors. I believe the H2 receptor is gonna decrease stomach acid, which going to like raise the pancreas so you get less pain.
Yes, exactly. And D, when you talk about the nerve block, it will relieve pain in about 50% of patients or people who undergo the procedure. But this is not the initial measure for pain control. So that's why C is the correct answer, because chronic pancreatitis, chronic pancreatic pain control measures include exogenous enzymes. So we have to give pancreatic enzymes as an exogenous medication, because that will because that enzyme stimulated by food is thought to cause pain. So the pain usually resolved from again, the presence of food in the GI is going to stimulate the pancreas to produce the enzymes. So when we give these enzymes, we have to give the antidote. We have to give the blockers to prevent the pain associated with from that enzyme. So when you give the enzymes, they are coupled with the H2 blockers, the H2 receptor blockers, or PPIs. You can give even PPIs is also be effective. That will block the action of the histamine in the stomach and prevent the effect of the acid, of the gastric acid, from destroying the line from the affecting, because remember that the lipase, it's a very strong chemical that is going to destroy the fat tissues, the gastric tissues and the GI tissues. So the H2 blocker is going to create like a wall, or like protective agent, or protective, like, barrier from, to prevent the enzymes from affecting the tissues. So that's why C is the correct answer. The last, I believe, question, the nurse has been assigned to care for 4 patients. Now, which client or patient should the nurse plan to assess first? And this is another like prioritization question. So we have a patient who has chronic pancreatitis, reporting pain level of 6 out of 10. And you have a patient with esophageal varices who has flu and coughing for the last 30 minutes. We have a patient, the third one, open cholecystectomy 15 hours ago, has been stable through the night. And then the last one, liver cirrhosis with jaundice, who has itching all over the body. Now, which one is this type of question? And I think we answered a few similar to this question in the past. The principle of it's a clinical judgment question, and also it requires that we have to eliminate the items or the answers in which that the manifestations are expected within that disease process. The management is expected, or the complication is expected almost in all patients with this disease. So which one is out of the expectations?
Professor, is it B?
B.
B, yes. Yeah. So the bleeding esophageal varices are the most life-threatening complication of liver cirrhosis. Coughing can precipitate the bleeding episode. And that's why the patient should be, the nurse should be assessing that patient first. And I believe that concludes the review. Just share.